Good day everyone, I am Crezyl and Castañas, and today I am tasked to discuss the cryptogenic organizing pneumonia or COP. COP is formerly known as bronchiolitis obliterans organizing pneumonia or BOOP, is a form of idiopathic diffuse interstitial lung disease. COP is believed to be a consequence of alveolar injury. This condition is characterized by the formation of organized buds of granulation tissue obstructing the alveolar lumen and bronchioles, resulting in respiratory failure. So what are the symptoms of COP? COP often begins with what seems like a flu-like illness. Most patient experiences SOB with exertion, dry cough, and weight loss. If the disease progresses, you can have SOB even at rest. In rare cases, patient may have chest pain, joint pain, night sweats, or cough up blood. The most common symptoms of a COP include persistent, non-productive cough lasting 2 to 4 months, fever, chills and shaking, SOB, fatigue, loss of appetite, and weight loss. Next is, what are the risk factors for cryptogenic organizing pneumonia? First is inflammatory diseases. People with inflammatory diseases like lupus, rheumatoid arthritis, scleroderma, multiple sclerosis, or inflammatory bowel disease have an increased risk of developing COP. Next is age. The average age of someone diagnosed with COP is between 50 and 60 years old. Next is medications. A condition similar to COP may occur as a side effect of certain medications. Other risk factors for organizing pneumonia include infectious pneumonia, organ transplantation, radiotherapy, and exposure to toxin. COP is called cryptogenic because the cause is unknown. It can affect anyone regardless of gender, ethnicity, or race. And most people with COP don't smoke, meaning smoking is not considered a risk factor for the development of cryptogenic organizing pneumonia because most patients with COP are non-smokers. Next is the pathophysiology. So it begins with an unknown insult or trigger. This could be an infection, toxin, or autoimmune process, but in most cases, the exact cause remain unidentified. This insult damages the alveolar epithelial cells, disrupting the delicate barrier between the alveolar and the bloodstream. And then nagkakaroon ng alveolar epithelial injury. So once the alveolar epithelial cells are injured, plasma protein start to leak in the alveolar space, and this creates an environment that attract inflammatory cells. That's why nagkakaroon ng recruit of inflammatory cells. The leakage of plasma protein serve as a signal, recruiting mononuclear inflammatory cells, including macrophages and lymphocytes, to the site of injury. And the next is, in the first stage of the disease, fibrin band form within the alveoli, leading to the infiltration of inflammatory cells. And this is the early stage of tissue organization between or within the alveolar space. Next is the stage 2, proliferation of fibroblasts. Fibroblasts begin to proliferate. These cells lay down a reticulin framework, a type of connective tissue scaffold that help organize the repair process. Next is the alveolar cell proliferation and re-epithelialization. Meanwhile, alveolar epithelial cells start to proliferate. They re-epithelialize the basal lamina, which is a critical step in restoring the alveolar basement membrane, and this process is essential for maintaining lung function. Next is the organization of fibroblast and connective tissue matrix. In the final stage, fibroblast and the connective tissue matrix organize into granulation tissue, and this granulation tissue partially replaces normal lung architecture, which may lead to decreased lung compliance and function if not treated. So next is the anatomy and physiology of cryptogenic organizing pneumonia or COP. So the affected system is the respiratory system, and the primary component affected is the lungs, especially the alveoli and the distal bronchioles. The disorder primarily affects the smallest airway and alveolar spaces, which are critical for gas exchange. So what happened in that area? There is a disruption of normal functioning. The alveoli are typically responsible for the oxygen and carbon dioxide exchange between the lungs and the bloodstream. In COP, this process is disrupted due to inflammation and fibrosis. So what are the changes that occur? First, alveolar epithelial damage. Second, inflammatory response. Next is formation of fibrin bonds. Next is fibroblast proliferation and matrix formation. And lastly is the granulation tissue plaques. So why these changes leads to symptoms? First, we have cough. The presence of inflammation and granulation tissue stimulates sensory nerves in the lungs, causing persistent coughing. Next is shortness of breath. Fibrotic plugs reduce alveolar ventilation and impaired gas exchange, leading to difficulty breathing and reduced oxygen levels. Next is fatigue. Impaired oxygenation reduces energy production in tissues, resulting in generalized fatigue. And next is fever. The inflammatory process in the lungs triggers the release of pyrogens, leading to fever. So next is the medical management. First is the diagnostic process. For the clinical evaluation, persistent dry cough, dyspnea, and fatigue are noted. Includes infection, malignancies, or other interstitial lung disease. For the test and imaging, we have the chest x-ray, so it shows bilateral patchy opacities. High-resolution CT displays ground glass opacities and patchy consolidation, often subpleural or peribronchial. Next is the pulmonary function test, reveal a restrictive pattern with decreased gas diffusion. Next is the bronchoalveolar lavage, helps rule out infection or malignancy. And lung biopsy confirms diagnosis by identifying fibroblastic plugs and organizing pneumonia pattern. For the blood work, CBC, CRP, and ESR to assess inflammation, O2 immune panels to rule out connective tissue disease. For the medical treatment, we have the pharmacological. First is corticosteroid, immunosuppressive therapy, and antibiotic. For supportive therapies, we have oxygen therapy, pulmonary rehabilitation, and lastly, we have the monitoring, so regular follow-up imaging and PFTs to track disease progression and treatment response. For the surgical management, we have the indication for surgery. Surgical intervention are not typically required for COP unless a biopsy is needed for diagnosis. And next, we have lung transplant, considered in severe refractory cases where medical therapy fails and respiratory failure is imminent. For the nursing management, first we have assessment. Key areas for monitoring, so vital signs, monitor respiratory rate, oxygen saturation, and heart rate. For the physical examination, assess for dyspnea, crackles on auscultation, and fatigue. For lab result, monitor CRP, ESR, CBC, and ABG for signs of hypoxemia or inflammation. And PFT result, track changes in lung volumes and gas diffusion. For the interventions, first is the nursing action. Administer prescribed corticosteroids and monitor for side effects. Provide oxygen therapy as needed. Educate the patient about medication adherence and pulmonary rehabilitation exercises. Assessed in energy conservation techniques to manage fatigue. For the lifestyle modification, encourage smoking cessation and avoiding respiratory irritants. Promote a balanced diet and hydration to support overall health. For the patient education, emphasize the importance of medication adherence to prevent relapses. Teach the patient and family about recognizing early signs of disease exacerbation, and provide guidance on coping strategies and managing stress. For care planning, focus on improving oxygenation, managing symptoms, preventing complications, and supporting emotional well-being, and then collaborate with a multidisciplinary team for comprehensive care. For the nursing diagnosis, first is impaired gas exchange related to fibrotic plugs and alveolar inflammation, as evidenced by dyspnea, hypoxemia, and abnormal ABGs. Next is fatigue related to impaired oxygen delivery to tissues, as evidenced by patient report of exhaustion and reduced activity tolerance. For the risk of infection related to immunosuppression from corticosteroid therapy, as evidenced by elevated WBC count and potential exposure to pathogens. That would be all. Thank you.